Hello, sir.
Yes, hello.
Good morning, sir.
Good morning. How are
Nice
you?
to talk. I'm very fine, sir. Nice to talk with you after a long time, sir.
Yeah.
Sir, after around 10 days, 10 days of that that workshop, I have just posted one case, sir.
Uh,
That is 2 years old. Uh, 2 years old.
o-
L45 PIVD, sir.
okay.
So, do you want to give me some? As I have posted the first case. Is there any two lines where I should pay more attention because I am different from others? This is the first time I'm going to
Yeah,
attempt.
I'll just see the thing again and give you whatever tips are needed. I saw your posting.
Yes, sir.
Mm, just one moment. Mm. You have put it on our group or you have put it, I think I saw.
Uh, no, sir. I don't have any MRI picture or anything. This
Okay, okay. So then
I
you
can just.
ask your question.
Yes, sir. The something different is she has just been migrating on different foot. That is central to right paracentral disc. So previously she has right-sided pain. Right now she has the left-sided pain, left leg pain. So it does not look very straightforward case, but still I have to start
What,
somewhere.
what
So
sort of images do you have with you now?
no, sir, sorry, sir. I just it was the image was a little old, around 8 months back. So I ordered for the new MRI. So I did not take the take that MRI. I should have, but I just can describe a little. It's like that, sir. It's
I understand, but you see, for me to tell you something more than what we have just talked about, I need to have at least one image
yes,
where I
sir.
can tell you that this is the point of landing and this is where you should go.
Yes, sir.
So whatever image which you have, you can send me. I mean,
Okay,
after
sir.
I see the image, I can be a
Okay.
little more practical
Okay,
about
sir.
it.
More precise. Okay, sir. I got your point. I'll try to get it, sir. I just
Yeah, yeah, please. Whatever. I mean, at least the X-ray, at least something which we can relate to,
yes, sir.
which will be easy to talk about. Otherwise, what happens? It becomes too vague,
Okay, sir. Okay, sir.
and we may not be talking about the same thing. We
Yes,
we
yes,
may
sir.
be referring to two different things,
Okay, sir.
and so we should be able to talk about
Okay,
the same thing. So once we have,
okay, sir. Okay,
yeah,
sir. I'll try to get the images as soon as possible. Whenever I'll get, then I'll post to you, sir. Okay, sir.
yeah, okay, sure, that is perfect.
Okay. Thank you.
Yeah, thank you. Welcome.
Thank you. Yes. Yes. कसैको त मेरै त होला अरूले त लाउन सक्दैन चाहिँ
Okay, so good morning, everyone. Are you able to hear me?
Yes, sir. Good morning.
Yeah, good morning. Thank you very much. So we would be starting now within a minute. And the basic idea of doing this webinar is to discuss certain issues which all of us face in our day-to-day practice. I mean, some of you have heard me, some of you have seen what we have done recently in our workshop in Derband. Some of you have, in your own practice, seen the various things which we have been mentioning or talking about. So let us start. Let us start interacting on this issue. Basically, this is not a one-way webinar. I would like you to mention about what you feel about these things. What are your perspectives on these issues, so that we go along interacting on these issues. So I'll just start sharing my screen and would start with my short presentation, which I'll be presenting in parts, and then we will be able to speak on that. Are you able to see this? Are you able to see what I'm sharing?
Yes, sir.
Yeah.
Yes, sir.
Yes, sir. Yes, sir.
So what you could do is you could interact with me by either raising your hand, or you can start talking by putting your video also on, so that I would know who is speaking. Of course, I can know from the screen also who is talking, but it would be easier if I could see who is speaking on this. So what are the issues which we are going to touch today? The issues are likely, which I mentioned here. The first thing is we are not trying to recycle any past surgery under minimally invasive spine surgery names, because the main objection which I have about the recycling of the past surgery is that there's a complete absence of attention to the upper zone, as most of you know. You see, we have been talking about this upper zone or upper part of the foramen, or the canal which lies above the upper end plate of the disc, from the upper end plate of the disc to the pedicle above. And there is a complete absence of reference to that area in open surgery. Then I would like to show you from a recent book which has come about minimally invasive surgery, where they're talking about en bloc, ligamentum flavum, excision, etc. And there were good illustrations which has come from the Barrows Institute, and I have picked up a few of those illustrations to talk about these points, which are commonly covered under minimally invasive posterior midline surgery. And then we will touch on certain things which people in open surgery remove, and we would like to listen to their rationale and probably talk whether is it really necessary, is it the right way to do it. Then we would talk about our understanding of the ligamentum flavum, and we will question this point, that is it that we only decompress the posterior structures. And then we, of course, would like to go to the battleground, that is the lateral recess or the lower zone for us, where we will be really having a big debate on the open surgeons and ourselves who do it transforaminal. And then lastly, I will try to mention why our concept, why my concept is important, and what is this three zone concept. So let's start talking about it. Now, this is the illustration which as I mentioned, from a book, which is a recent book on minimally invasive surgery of the spine. And you can see in the picture above, the yellow part which they have marked. The yellow part on the upper lamina, that is lamina of L4, is to be removed. Why? Because the ligamentum flavum is attached to the under surface of the upper lamina. So when I'm talking about L4-5 interlaminar space, the ligamentum flavum is attached to the ventral surface of L4. And conventional literature says that it is attached to the upper edge of L5 lamina. Please mark my word edge. It is attached to the upper edge, not on the inner surface of the lamina. So what you will see is, then you go to the image on the left lower side, and you will see this is what we imagine when we are doing an open surgery or a penetration. We would like to go interlaminar, we like to go paraspinal, we like to remove a part of the upper lamina, and then we'll like to remove a small edge of the lower lamina, which actually makes us access the ligamentum flavum. So there is a complete obsession with the ligamentum flavum when a posterior midline surgeon is talking about lumbar canal stenosis. And on the right lower side, you will find that you are able to see the tube which has been put on the interlaminar space. The lamina above has been removed. The edge of the lower lamina has been removed. A portion of the facet has been removed, and the ligamentum flavum also has been removed. So this is the idea when we do the open surgery. Now, this is a picture from the same book, which is conveniently biasing us or showing us the triangle which everybody is very fond of, where the triangle is supposed to contain the ligamentum flavum. Now, for us who classify these into zones, this is the middle zone where you see the facet joints, you see the foramen, and you do not see the exiting nerve, you do not see the dorsal and you will find that you are now, if you go from left to right in these images, on the left you have the MRI which shows you the ligamentum flavum. The second picture from the left is showing the thickened ligamentum flavum, which is a very, very attractive thing to look at in this image. And in the third image, we have done this medial facetectomy with a laminectomy, which was much more conventional in the past. And the fourth image, or the rightmost image, in the newer version of the same recycled past surgery. That is, you do one-sided laminotomy and go on the other side under the lamina, taking out the ligamentum flavum. Now, this is the understanding which we have from our posterior midline open surgery. So there are several objections which I have about it, and I would like your perspective on these points as we go by. Now, the next point is this is from a very, very old paper which talks about what we really do. Now, if we go to the upper part of the picture, you will find they are talking about mesial facetectomy by using osteotome. So we do a mesial inferior facetectomy, and then we expose the superior facet. And in the lower part of the picture, on the left lower side of the picture, where my cursor is, you can read 3/4 superior facetectomy. So please mark my word, this superior facetectomy is done with an intention as to de-roof the lower zone or the lateral recess. And this is the traditional approach to what we do in case of lumbar canal stenosis, where somehow we must work on the posterior wall. We are really not taking cognizance of anything apart from the posterior wall. There is no mention of the foraminal stenosis. There is no mention of anything happening in the upper part of the foramen. Just one moment. Somebody is asking me the code for the image. I mean, somebody was sleeping. Okay, so this is what we have been talking in the posterior midline surgery when we do an open surgery. And now what we will have to first of all talk about is it really necessary to remove all this bone? So I would like you to comment on this one by one, or whosoever wants to comment on this. After I finish this one or two more slides. Now, this is a picture from the same book, Minimally Invasive Surgery of the Spine. On the left, the person is lying down in the canal, looking up at the roof of the canal. And on the right, he's seeing the roof. The yellow thing is the ligamentum flavum, which is now being called as a curtain. And through the curtain, you can see the facet joint and the posterior structures. Now here, please note that the ligamentum flavum is on the under surface of the upper lamina here. If you see the L3 lamina, the ligamentum flavum almost covers half of it. Whereas in the lower part, it is attached to the edge of the lamina. Okay, the lower attachment of the ligamentum flavum is to the edge of the lamina. Then this is from the same book, which is talking about minimally invasive excision of the ligamentum flavum. So what they do is they put their Kerisons here in the upper part of the picture. They remove the lower edge of the upper lamina, which anyway is elevated. That means you can go under the edge. Here, if you can see this model, you can go under the edge of the upper lamina, and then you start cutting it, and then you enter the canal, and then you remove. Then you go towards the lower edge. You may use a drill, etc., and you remove this end block, and you create this window where you put your tube, etc., etc. So this is the way the surgery is executed. Now, in this picture on the left, you will see that you have the ligamentum flavum. Now, see the fun. In the picture on the left, you will find the dural sac and the central ligamentum flavum. There is a huge gap there in the posterior midline. The ligamentum flavum is not touching the dural sac, but the ligamentum flavum is in close contact with the posterolateral aspect here. Okay, this is very important. And this is the facet joint. This is a middle zone axial cut. On the right side, what is shown is we are shown the lamina of L3, and there is a magenta colored circle and there is a blue colored circle. So what is being talked about is the upper circle you use to remove that part and the lower circle you use to remove the other part of the ligamentum flavum. So you will find that all this talk is about working on the posterior wall of the canal and remove the ligamentum flavum. Now here suddenly the perspective had changed. Now this is a picture from the same book where what they are talking about, they call it as a napkin ring problem. That is this area on the left, the first image on the left, the ligamentum flavum is pressing on the dural sac. The upper part of the ligamentum flavum, which was under the lamina above, which is seen in the picture on the right and the third picture on the right, that has been removed. And what is being highlighted is the upper edge of the lower lamina, which is supposed to press on the dural sac and create claudication. I personally feel this is absolutely without any evidence anywhere in the literature. So what I'm going to do is now we are going to stop for a few minutes where we can interact on this point that in the open surgery, people are talking about removal of this part of the lower lamina, removal of the ligamentum flavum, and they are neglecting this part of the ligamentum flavum, which is posterolateral, which actually is more important according to our understanding. Then they are talking about removal of so much of bone which covers the roof of the lower recess or the lateral recess. And this image is sort of iconic. If you see the image which I was trying to show, just one moment. Yeah, this image and this image. This is what has been hammered in our head, that this is ligamentum flavum which needs to be removed if you are trying to treat upper canal stenosis. So let me clarify one point here, that this image which you are looking at on the left first and the second is entirely related to middle zone, and this is central canal stenosis according to the classic description. For us, it is the middle zone problem, where the problem is not only posterior, but it is also in the foramen as well as in the front of the dural sac. So now I would like to have you to comment on this. Any one of you who would like to support what is being done in the posterior midline surgery, anybody who feels that this is the right way of doing it. I mean, I'm not saying this is wrong or this is bad or something. I do not believe it. There is no evidence anywhere in the literature to say that this ligamentum flavum must be removed. It is all legacy. It is all an extension of a posterior midline approach and removal of more and more bone, assuming that the removal of the bone doesn't do anything to the stability, and removal of the ligamentum flavum alone, not paying attention to the upper zone, not paying attention to the foramen, is the style of the day, which I personally do not believe or do not support. So the topic is open for discussion. Any comments are welcome. Let us discuss this point, that what do you think should be the rationale in this surgery where you see so much is being done, starting from here. Yeah, so anybody who wants to comment, you are welcome. Please start your video and start your audio and please comment. I would like Dr. Ashish to give his comments. You are a senior person. I'm sure you have done multiple surgeries like this. What is your perspective on this when we talk about the real truth in lumbar canal stenosis, where we are now talking about the structure which compresses the nerve roots or the venous drainage of that, so that we understand what causes the symptoms, the pathophysiology.
Good morning, Dr. Gore. Good
Yeah.
morning, everybody. Can you hear me?
Yeah, sure. Go ahead.
Right. So I will answer your question in three parts.
Yes.
The first part is, say, when I was trained, what you are saying was, biblical truth, that you just go and take out as much bone as possible. You make a wide opening. The wider the opening, the bigger the surgeon and the more efficient surgeon you are. However, the ligamentum flavum, as you rightly said, in the mid zone or upper zone and lower zone, it was only the ligamentum flavum which was concentrated on. And that too, only the part which was easily removed from over the dorsal surface of the thecal sac. Nobody paid attention to what was happening on the sides. But as later we grew, and this nobody taught us, but what we saw was that the ligamentum flavum used to continue far more laterally and almost to the anterior of the root. And so by common sense, we started removing a lot of ligamentum flavum laterally. In fact, so much so that we believed, and I was one of them, and I think my colleagues of my generation believed, that unless you take out the lateral part of the ligamentum flavum, it is rubbish. It is not going to work. The root has to be free. So we started using thin upcuts, 1 mm, 2 mm. Neurosurgeons are very fond of delicate instruments. So we started using 1 mm, 2 mm upcuts to go right up to the anterior edge of the ligamentum flavum. And some of us were successful. Some of them gave it up because it was a little difficult to go and there would be a risk of root injury. So, however, now if you talk to me today, I removed the ligamentum flavum right up to its anterior edge. And as you showed in one of your diagrams, it is the part which is attached to the lower vertebra, the lamina and the facet, which is pressing, even if you have removed the ligamentum flavum in the traditional way. But some of us have started taking care of that through the posterior approach by using undercutting of the surface, and undercutting of the facet joints is now a standard procedure, even by conventional standards. So that was our journey from, removing just the ligamentum flavum to going and trying to go lateral. But yes, in that process, we did a lot of wide opening and this and that, and unnecessary things were taken off, increasing the risks of so many things, including instability. Now, that was conventional. Now, what we are doing with your system is that you are able to attack it directly from the lateral side. So this is, I would not say that the posterior approach has been wrong all along. Only thing I would say, the traditional approach has been incomplete and unnecessarily, if I may use the word, violent. You are too violent in surgery to remove that 2 millimeters of ligamentum flavum. You are removing 20 centimeters of tissue, both bony and soft tissue. However, in what I saw in your workshop and in your system, you can do that much more sophisticated manner, in a much more eloquent, sophisticated manner, so that you're not touching the rest of the spine unnecessarily. So it's a paradigm shift, and that's what I would say. And I think the main area of attack should be, say, 4 to 5 millimeters all around the nerve root. If I may just put it this way, that you are just going to do whatever you have to do, say 4 to 5 millimeters all around the nerve root. That's where the pathology is. And for that 5 millimeter tube around the exiting nerve root, You are removing almost 20 centimeters of bone, ligamentum, so-called ligamentum flavum, and you are trying to damage the root or the thecal sac. We must understand that once we are going from the posterior approach, God forbid there is a dual tear, and it happens. Let's face it. I have had it so many times, and everybody has had it.
Yeah.
So we are not scared of that. That's a different issue. However, if the tear is on the shoulder of the nerve root, or worse, it is at anterior to the nerve root sleeve, then you are in a soup.
Absolutely.
And you have to be really experienced to know what to do with it. And I think most of us gray-haired ones know that the best way to manage it is not these new Duragens and all sorts of seals and all. It is still the best way to manage it is to crush muscle, wrap it in a Surgicel and put it there and forget. So these are the handicaps of the posterior approach. You are doing too much to achieve too little. And that's a very uneconomical way or a very inefficient way of doing it. That's what my comment. I mean, yes, you can achieve the same objectives with posterior approach if you are meticulous, if you know what you are doing. Not many people do it. They just want to get away with doing a ligamentum flavum excision. So that's where I would put the conventional approach and your approach.
Okay, I have 2 points which I would like to raise from what you have just said. Number one is that we are likely to cover the anterior and lateral aspect of the nerve when we go through the foramen.
Exactly.
Which I think is very difficult when you go from behind.
Exactly, yes.
Yeah. And the other thing is, if we talk about the pathophysiology of lumbar canal stenosis giving claudication, then most of us have been talking about the axilla and the venous and the arterial system involved in that part. And then what I find very funny is that a person is talking about an area which must be concentrated upon in pathophysiology part of it. The moment you talk of surgery, he suddenly moves away to the midline and starts cutting the midline, which is something extremely unusual in a scientific explanation. So all this jugglery of terms, and then saying that, the foramen is the lateral canal and the central canal is really the medial canal, but it is really central. And inward, inside you know that the real problem is posterolateral rather than posterior. But continue with posterior because we have been taught that there is no alternative to posterior midline axis, which I think is the real issue at hand. And we should be able to hammer that out, at least to the extent possible, with today's technology, today's understanding, today's imaging, etc. So before I go ahead, I would like some more comments from whosoever wants to say things about this. Yeah. Dr. Tarun, you would like to say something?
Yes, sir.
Yeah, please go
Sir,
ahead.
I totally agree with your concept, sir. Like previously, I was trained in open surgery. Sir, one question always keep in my mind that what is the difference in function, like post-surgery, midline surgery also gives satisfaction to the patient. And with our technique, we are very much close to the pathology and we are dealing totally 100%. So in my mind, it is there that in midline, we were missing something and some recurrent cases were because of this reason. Sir, like, am I right in this?
I would say that we should be courageous enough to accept that in posterior midline, we were doing too much, as Dr. Ashish said, and that too much part was contributing a lot to the morbidity. In that era, since it was proposed that there is no alternative, all of us were justifying that, saying that, "Arey bhai, aise hi hota hai." That is what it is. You have to accept it. I mean, we used to tell the patient that, I remember we had a conference way back in 86, 87, when Dr. Cloward had come to Goa. And Dr. Cloward said that today's surgery is not complete because when you do a discectomy, you give back pain. When you do things for back pain, you give more morbidity for a longer time, etc. So he used to propose his PLIF, posterior lumbar interbody fusion, And he was the one who used to talk a lot about medial facetectomy as to deroof the nerve which is traversing and entering the root canal. But all these days, everybody knows that the exiting nerve and the traversing nerve, which are around the pedicle, is the real core target in open surgery. But funnily, in the past, it was called as hidden zone of McNabb. I mean, that was a part which was very difficult to reach. Now, see the fun. The glamour was attached to your inability to reach, and then your ability to cut the bone with big caissons of 1 mm to 5 mm, etc., etc. What I feel is we have enough courage now to accept our limitation and move on to the real target, which is now supported by more imaging information and inputs, which supports what we are doing. So I would go ahead with the truth of ligamentum flavum, as I call it, and then we will again talk about the same issue when we come back. Yeah, Dr. Hillol, yes. Yeah, you would like to say something?
Sir, I think that basically the change is going to be in the image perception.
Yes.
I think that that is where anybody who is interested in this area has to redefine in his mind the compressive element. And all along, actually, the midline approach has been an approach of convenience and an approach of familiarity. So the thing is, that, okay, for a long time, I will not have any problem. I remember quite a long time back, the way to find out on the table, when I say long time back, it was almost, I think, 25 years back, that we were taught that you just put a hook, when you have seen the thing, you just put a hook into the foramen. And if a 2 mm hook passes, that means there is no lumbar canal stenosis, So the concept was, and professors were doing it. It's not that we residents were doing it. And if it will pass easily, then the thing is, that means that there's no lumbar canal stenosis, and the resection, it was the end of the surgery. And ligamentum flavum was just a convenient anatomical landmark. So from there, I think to focus primarily from the lateral anatomical aspect has been, like one of the speakers said, a paradigm shift, which has to be noticed and appreciated, and that will make the surgery much more relevant in today's arsenal. That's what I feel, sir.
Yeah. I would add one more point to that, is that gives us the ability to do our surgery under local anesthesia. That is one thing which will make it more and more relevant to the population at hand, because lumbar canal stenosis per se is seen in a senior age group. It's not the younger people or the middle-aged people which we deal with. Maybe occasionally we may, especially with a congenital shortening of the pedicles, etc., with additional disc herniation, etc., etc. So what you say is absolutely agreed, because our mental imagery is so built up in the past that we have been, I remember when I started talking about transforaminal, people used to be sort of confused. They used to look like this and say, oh, I mean, how do you go there? So I used to say, okay, now this is you and I go from the side. So initially, for first 1 or 2 years, it was just this statement that I go from the side. I go from the side. That was the only thing which we could interact on. And then later on, we of course started talking about more and more of the anatomy of foramen, then the exiting nerve. I remember a day when I used to tell my MRI specialist that, why don't you write traversing nerve? Why don't you write about annular tear? So he used to say, "Arey sir, there are very few people who understand this terminology, so I don't write." I said, no, but your job is to write it. Let people slowly wake up to the fact that the reality is different than what it is proposed to be. Okay, so I'll come back to the presentation again and go ahead with the ligamentum flavum part of it. I'm just showing the same thing for those who have joined late. This yellow thing is the upper lamina, the edge of the lower lamina, which is removed in the open surgery. And then this is what we are told about central zone. This is what we are told about facetectomy in the lower zone. This is the ligamentum flavum, the en bloc excision, and this is what has been highlighted, the upper edge of the lower lamina with the ligamentum flavum, etc. Now let's see what is the real truth with the new imaging specialties. Before that, I would like to point out to you that this is a paper which is a very, very important paper in the literature. This is in European Spine Journal, where this is a ventral dissection of the ligamentum flavum. Please mind my word. Please listen very carefully. This is a ventral dissection. That is, the body has been removed, and you must have seen this model which Dr. Ankit Madaria had prepared, and we had talked about this during our work in Derband. Now this is where we have, I'm sorry, I had held it upside down, so I apologize for that. I'll just try to show this again. This is the way it is. I'm just removing the bodies, and what you're looking at is this. Now the upper part, the blue part in the upper part is the upper lamina, which has the attachment of the ligamentum flavum to the ventral surface. And the lower part, if you see, is just the edge of the lower lamina where the ligamentum flavum is attached. The image in front of you on the screen is showing you the dural sac in the bed of the ligamentum flavum. You can see the LF and LF is marked. The one LF which is marked on the right part of the image below the L5 root towards the axilla of L5 is the SAP, superior articular process. And the left side LF with a white streak in that yellow, in that black arrow is the central zone. And now I'm going to make a very important statement. Please listen carefully. What I'm saying is this ligamentum flavum, which is above the SAP, and this ligamentum flavum, which is on the inside of the SAP, are contiguous. These are part of the same structure. So if I go in the axilla of L5, as you can see on the image on the right, I can go around the SAP for the inner part of the ligamentum flavum. I mean, this is a very, very important part which transforaminally can be accessed under local anesthesia. And since the patient is awake and aware, it is extremely safe. You will not be damaging anything. I'll repeat, you go above the SAP here where the right side black arrow is, and then go around the SAP and work on the inside of the SAP. Now, this is a picture from the same paper. The name of the author is Okuda, and it is showing this bed of the dural sac. The C is central, S is subarticular, F is foraminal, E is extraforaminal. And if you see the S and F, you will find the S is the edge of the facet, or the facet margin, or the facet edge. That is, the facet joint is like this. So these two things which you see, the S on the right and the S on the left, is the facet edge. Now this is a 3D fusion imaging where the greenish yellow, I mean the yellow is the ligamentum flavum, the orange is the nerve, the greenish is the disc, and the black roundish thing which I'm pointing out on the left. Now I think, let me draw. Okay. Now can you see this, what I'm drawing? Okay, that is the pedicle. That is the pedicle. This is the exiting nerve above, and the traversing nerve is coming below this ligamentum flavum and going out here. What I was referring to is this area, which is extremely important. This is something which is a key to the stenosis in the upper part of the canal. The other key lies here in the lower part. So we'll go ahead with this. Now, what is this? Okay. This is another picture for the lower zone. You will find that this is the ligamentum flavum in the lower part, which is coming in the way of the nerve which is going out. This is the lower zone. We'll be talking a little more about it soon. Now this is, now give me a moment. I need to have the eraser. Okay. So this is the lower part or the lower zone. Then this is a very important cadaver picture or a cadaver dissected picture. Please see this. See the lamina here. It is labeled as lamina, the middle part. Now this lamina is the upper lamina, let us say. The lower half of this lamina has the attachment of the ligamentum flavum. Now this ligamentum flavum goes back. We are looking at it from the front. This is the facet edge. This is the facet edge. Now I call it as a pincer. There are two arms of this facet edge, one on this side, one on this side, and this is actually pinching the dural sac in the middle, in the central zone. So this is the middle zone or a central canal, and this is the lower zone towards the lower part, and lower zone can be seen closer to the pedicle. We'll be seeing it a little more now. Now this is a cross section from a 3D model. This is towards the lower end plate of the disc, and you will find that the exiting nerve, the traversing nerve is entering the lateral recess. It will be going out from this foramen like this. And you will also find that most of the roots are freely floating inside the dural sac, and there is nothing in the posterior midline which is compressing the dural sac. It is actually this posterolateral corner which is subarticular and little bit of foraminal. This, of course, when it is a complete lid-like thing, which you see in the lower part of the foramen, is called as the operculum of Forestier. That it's a lid on the foramen, which is of the soft tissue in the foramen. So this, in short, was about the ligamentum flavum. Now, I would again like to interact with all of you and have some comments on this, that this is our new understanding of the ligamentum flavum. I have not talked about anterior causes. I have not talked about causes in the foramen. I'm just talking about causes as were perceived in the past and now as being improved in our understanding about ligamentum flavum. It is not important in the posterior midline. As Dr. Ashish commented, it is more important below the facet joint. It is also important in the lower part of the foramen, the lower notch, etc. So we'll be talking more about that very soon. But before that, let's have some comments on that. Pravesh, you wanted to say something? You can start your video, let people see who is that. Yeah.
Morning,
good.
sir.
Yeah, hi, good morning.
So the images were very nice, and it's more easy to understand when you speak rather than when we just see them.
Yeah.
So the understanding is changing, and it's changing for us also as a pain physicians, and I'm learning a lot through it. That's what I can say as of now.
Okay, very good. So, any more comments on the ligamentum flavum thing? I would say, in short, that we had an idea of the ligamentum flavum, and as Dr. Hillol mentioned, our mental imagery was dominated by that V with the ligament in the middle, which actually was an interlaminar ligament, not below the lamina. It was interlaminar, not, you see, please see the trick here. I'm showing you, and this interlaminar area here, okay, that ligamentum flavum was from this area, and when you take a cross section, it shows you as if it is in that V of the bone. Okay, it's not actually the bone which is there. It is a plain, simple, soft tissue which is lying interlaminar in the coronal plane, but in actual cut, it was shown to be under the bone. No, that was only under the upper lamina. So you see what happens is, in the traditional descriptions, everything is mixed up. Lumbar canal stenosis is one thing in traditional description, where you talk of posterior midline, you talk of lamina, you talk of ligamentum flavum. That's it, finish. There's no distinction between the exiting nerve and causes, traversing nerve intrathecal and causes, traversing nerve at the entry to the root canal and causes. I feel that these three different entities need to be refined, understood much better as surgeons who are responsible people and who are operating people under local anesthesia. So some more comments before we go ahead with our other, the zones and our understanding of transforaminal surgery.
Good morning, sir.
Yeah, good morning.
Shantanu.
Yep, follow.
Especially being into pain management, when I started learning this endoscopy, especially transforaminal endoscopy, and as I did MD anatomy, especially to know all this anatomy more, and for my other pain procedures, and I started doing dissections also, discussing with you regarding this ligamentum flavum, and we have seen really this is a new concept to understand the ligamentum flavum, which is there. Nobody has thought ligamentum flavum where it is reaching, where it was there. Everybody thought. Even when I talked with lots of our anatomists, they also not aware of this ligamentum flavum. That is the most important thing, because usually it is not required for teaching MBBS level, just to attachment of the ligamentum flavum that much enough. But when we are really giving clinical support to the patients, so then this anatomy has totally opened a new concept, and we should focus on this much more. It is not only helping in gaining more knowledge, but helping the surgeons also to support more precisely, reducing the surgical trauma and giving best results. Yeah, we can do a lot of things with posterior approach, but trauma also much more. That also we have to think. I used to tell the patients, you just compare with lap call. It was there 10 years back, and now the surgery is same, but the trauma is much more reduced. So in that way, I feel, so if we are giving maximum support through transforaminal, why unnecessary to go posteriorly? So that I felt through, and I will do much more dissection under your guidance, particularly ligamentum flavum. So let's see what I can do through being in the anatomy department.
Yeah,
Thank you, sir. And
that was very important. I would say that if I talk with many of my surgeon friends and ask them, why is it that you are still into posterior midline surgery, they definitely accept the point that when they were doing their anatomy lessons in first MBBS, probably they were paying more attention to the posterior midline as was taught in those days. And I think the revolution has to start from right from first MBBS, where we come across this anatomy, right up to our understanding and interaction with anatomists when we do the cadaver courses, where we need to demonstrate to the people. Now, there's one more area which I've been fighting for last 20 years with people, which unfortunately I think I succeeded only once, is that I've been asking all anatomy departments to have a CIAM and also to ask the imaging people to help them in getting a MRI and CT of at least one cadaver. You see, when we cut the cadaver, we have no mental image of what is lying inside. We go on opening and understanding, which is good. It is not wrong. But let's take help of the newer imaging modalities, which will make our life easy. The other point which I will comment on your mention is that it is not less trauma alone. The real secret is that we have understood where the symptoms are generated, and these symptom generators are sub-centimeter. That's why it is possible to do a stitchless surgery. It's not out of fashion. I'm not creating a new fashion out of something. What we are saying is we really know that our appreciation of the symptom generation is so refined, is so very fine, that we are able to say this is the spot where this problem is coming up. And it is, fortunately for us, close to the foramen or in the foramen, and therefore we are able to access it very easily. Now, unfortunately for posterior midline axis, what is happening is, I do appreciate the comment by Dr. Ashish that we are moving away from midline and secretly we are going under the facet. We are going in the upper foramen. As Dr. Hillol mentioned, we also pass a catheter in the past in the foramen and say that, okay, this is fine. This is good enough to sort of cover that problem, which is not true. Let us say that our past surgery was more of indirect decompression to start with. It came to a direct decompression, but that direct decompression involved more and more of removal of facet, probably leading to instability. Now, because we had good stabilization, that all thing was accepted, which for me, let's say as a position, I would say I do not accept it, because I do not want to fuse. I do not want to put the screws for no reason. Therefore, I would stick to reaching the symptom generating area through the foramen. Now we'll go ahead, and are there any more comments, please? I would like to know. I'll just try to make it a gallery. Yeah, Dr. Ashish, please go ahead. Yeah, you need to unmute yourself.
Dr. Goref, sorry for making a comment which is completely unrelated to the webinar.
Okay.
Amongst us, we have Dr. Hilol Kanti Pal.
Yes.
Who used to be my senior at AIIMS, in the thoroughbred Amazonian.
Okay.
And even amongst the brilliant students of AIIMS and everything, he was a stand-apart neurosurgeon. He is extremely cerebral and very accomplished, and he's written books on CV junction. I feel privileged to be there with him.
Yeah. I have been very lucky to interact with him on this concept for a long time now. And I will not disclose the secret on which we are working, but very soon you should be able to see that. So I'm also blessed by his help. And I would say he's not only cerebral, but he's also spinal. I mean, he covers both the areas very well. So Dr. Hillol, I completely agree with Dr. Ashish and his comments. And
thank you for your kind words, sir, of encouragement. I am highly encouraged to be on this forum. Thank you, both of you.
Yeah, I would say one thing over here, which also is a comment which is partly relevant, partly not relevant, is, you see, we need to co-create this concept. I am just taking the credit for a second only because I have taken all the negatives and all the comments from people laughing at me and calling me names and all that. That is over now. Now a stage has come for us to stand up and be counted. And this should be a co-creation. All of you should contribute to this concept, because you see, ultimately, I'm not answerable to anybody of you. I'm answerable to my patients, and I'm answerable to them because they come to me for a solution, which if I'm not able to sort of give, there's no point in my getting trained under X or Y or this training or that training. Now, I would also like to have comments from my colleagues, Dr. Palani, Dr. Adam, Dr. Mukesh Mohan, because I see them here in addition to Dr. Nordin Shafei. And so if you have specific comments, Dr. Yoganandan, so please comment on this before we go ahead with our concept of 3 zones. And yeah, Dr. Mukesh, please.
Yeah, yes, sir. Good morning, sir. It's a wonderful session. It is
Yeah.
an eye-opening to all. Having started endoscopy for the past 10 years, so I've started believing more and more day by day. Like even when addressing obese patients, especially when addressing obese patients, it is a luxury to operate via endoscopy You don't have to cut the muscles in the back and also not damaging the bones. And patients also recover very well. And we see the relief on table, which is much more satisfying. And I feel that is a complete work when we do foraminoscopy under local anesthesia, sir.
Okay, yeah, very good. I do remember one patient whom I had operated. She was a gynecologist weighing 118 kg. And she came to me crying and said, "Sir, nobody is ready to touch me and operate me because of my weight. Can you help me?" So I said, "Yeah, sure, I can help you. And the biggest help which I have is from you, that when I want to shift you from the trolley to the table, you yourself can go on the table. I don't need four people to lift you and put it on table, because that would add to your surgical charges. I have to have four attendants to shift you to the table." The jokes apart, I completely agree that the morbid part, or I would say that obese and elderly will be a deadly combination. A patient aged 70 who is obese, diabetic, hypertensive, coronary problems. I mean, you can't imagine what sort of morbid things we are dealing with. That is terrible. Dr. Abhay, you would like to have any comment? I mean, you seem to be. Please unmute and give your comment. Dr. Abhay Kothari. Unmute yourself. Unmute. Yeah.
Hello, sir. Still, I'm not practicing the endoscopy. Just I have purchased it 1 month back only. I will comment it when I start, sir.
Okay, no problem. So we will go ahead with the next part now. And okay, so now we are going to talk about our concept of 3 zones, as I have marked on the right side. The blue part, of course, I marked only half part of it, even though the real canal, the upper zone canal or upper canal zone is complete. I mean, it extends from one pedicle to the other pedicle, or one foramen to the other foramen. The blue part is the upper part, upper zone. The orange is the middle and the green is the lower. Grossly, I would refine that further. Now here on the left side of the image, or the left image, the upper zone is from the upper end plate of the disc to the upper pedicle. The middle is between the two end plates, that is the discal zone, and the lower, which I marked with a green circle, is inside the pedicle. Now this, as you know, is an image of the plastic model which Dr. Ankit Madaria has made. This is about 1.5 times bigger than the actual vertebral 3D model. This is the 3D printed model which he got for us and gave it to me very graciously during our Derwent conference. And here what I would like to bring to your notice is we have marked the ligamentum flavum with the blue ink. And you will see that when we go through the foramen, this ligamentum flavum in the upper part is much away from the dural sac, but the ligament in the upper zone, that is above the end plate, under the pars, is much more closer to the exiting nerve. It could be closer because of 2 or 3 more reasons. Now here we are looking at the same thing. I would like to bring your attention more to the right side image, where the upper body has been removed. And you can see the ligamentum flavum, you can see the facet joint, you can see the SAP, you can see the tip of the SAP, and you can appreciate the point on the left side image where we have removed the lower body, that if you go above the tip of the SAP, you can go easily on the inside of the SAP and tackle the middle zone also. Now, these are few things which I would like to show you. That is, number one is pedicle is lateral wall of the lower zone. This is the operculum, which I was mentioning, a lid-like soft tissue which is closing the foramen. The axilla of roots is between the exiting and the thecal sac. Please mind this. The axilla is traditionally conceptualized as between 2 roots. It is not actually 2 roots. It is exiting nerve and the traversing nerve inside the thecal sac. Please remember this very clearly. Axilla is between the exiting root and the thecal sac. And this number 4 is dorsaloid ganglion, is the lateral wall of Cambin's triangle. As you know, the Cambin's triangle is the exiting nerve, the thecal sac, and the lower end plate of the disc at that level. Now, if we see this very clearly, you will find that the roots also are more lateral in the thecal sac, even though we know that they are floating inside the thecal sac. The next image. Here, the facet joint forms a roof at the mid and lower zone. Here, the facet joint. It actually forms a roof at the middle zone over the discal area and in the lower part where the traversing nerve is now entering the root canal, as you can see very clearly here. Let me use this marker so that I think I'll be able to, where is it? Yeah, okay. So please have a look at this circle where the traversing nerve is entering this root canal, and this is where it is involved in stenosis. Now, number 2, which I have shown, is the root in the canal here, inside the pedicle. Number 3 is axilla. This is the axilla. Okay, this is the Cambin's triangle. Then the thecal sac as the medial border of the Cambin's triangle. Please remember, this is a very, very important part of the thecal sac because this is where the central canal stenosis. Actually, if you ask me, now onwards, today onwards, for example, we should start calling it posterolateral canal stenosis, not the central canal stenosis. These words should be banned. These words should be given up. The number 5 is SAP that grows into the facet, and then we have to understand that that is what will cause the further part of the stenosis. So I'm just removing this and we go to the next slide. Oh, what happened to my cursor? Just give me a moment. This cursor is behaving abnormally. I don't know why, but this seems to be stuck here. Okay. So here we go to the next one. I would just erase this. Okay. Now here, number 1, the medial facet, the medial face of the facet. What I mean is the inferior articular process coming from the vertebra above. That is, let me draw it here. This is the way it will be. So the medial face of facet coming over the thecal sac, this is what causes the central or the posterolateral canal stenosis. And number 2 is inferior articular process or medial facet inner face is important cause of lateral compression at the central canal in the middle zone. So this is that part. Now next is in central canal, there are no posterior midline compressing structures. It is always the posterolateral structures and or the lateral in the central canal stenosis. This is where the central canal stenosis. It is purely in the middle zone of our classification. Sorry. So this is what, again, I would stop here. We'll have a few comments on this, and then we will go ahead with our further talk about the 3 zones and 3 wall, 3 causes concept. So if there are any comments on this, please go ahead and let me know what you think about it. What I have tried to emphasize is very simple. In the upper zone, you have the exiting nerve and the axilla. You have the tissue on the top of the SAP. In the middle zone, you have the posterolateral tissue, or you have the inner face of the inferior articular process, which really causes the central canal stenosis. And in the lower zone, you have the traversing nerve entering the root canal. We'll be talking about the lower zone little more detail very soon. So if you have any comments, please let me know. Otherwise, I'll go ahead. If you want to make any comment, please unmute yourself and go ahead. Dr. Adam?
Yes, sir.
Yeah. So,
I just follow your teaching, and I've done so many of stenosis, lumbar canal stenosis surgery using your technique. But I did more for discectomy rather than stenosis. In doing stenosis, in my experience with your technique, I use your technique to ask the patient to bend backward. If the patient pain, like you said, that the cause is the facet, and the patient bend forward, that is cause the pain. The problem is the disc. I did your technique, and I found an advantage when I found the patient pain and bend backward. So I take out the ligamentum flavum of the SAP, the superior part, the knot of the SAP. But I have a problem in taking care the contralateral part, sir. So I relieve for example, I relieve the left part since the patient have left symptoms. I take out the left part, and the patient come other day with complaint in the right side. So how to tackle this? Should I open also the right side, or I just wait for the patient complaint to go away? Please.
you would have to go back to the history. If the patient says that my right side complaint is for last 2 years and the left has come up in last 3 months, you may take a chance of doing the right side first. Wait for a couple of days, maybe about 3 to 4 weeks. If the symptoms go away completely, fine. But if you are so convinced that both-sided anatomy change is same or of an extensive degree, then better you do a biportal surgery. Both the foramina should be accessed rather than going posteriorly. And I, for one, I was going to ask you a question with your experience of PSLD or posterior stenoscopic surgery. What do you have to comment on our understanding of the foramen and our understanding of the ligamentum flavum? I mean, posterior PSLD is just a recycled old surgery with newer tools. I'm not against it. I do appreciate better vision. I do appreciate that it is done under irrigation, which makes the picture very clear. But I do take an objection to the same old philosophy, which is actually outlived. I mean, I would not agree with the philosophy part of it. The technique part is excellent. The visualization is very good. But whatever said and done, it is the same old surgery in a new bottle, in a new tools. So what is your comment on that? I mean, since you do it, let me know. What do you think about it?
I did several surgery of PSLD. I'm a beginner. I try all kind of endoscopic surgery, sir.
Okay.
So I can learn what is the advantage and what is the drawback. It is like studying a companion between religion. So I try to follow all religions, sir.
Very
like
good.
an Indian movie, the Alien. You know the Alien.
Yeah.
Alien try to pray to all God, and he try where is the right God should I pray. I mean,
Yeah,
I'm doing this when I'm doing PSLD. I have an objection in my heart that I cannot take out the flavum. I can see it in the flavum in the lateral recess, but more laterally. I mean, I cannot take it. I try to bend my scope. Push to the sphenosus to reach the lateral recess. I mean, like you said, to reach the middle zone. I try it. I can see it, the flavum, but my Carrison cannot take it out. I was just thinking that I should cut the base of the spinosus, so I can shift the spinosus, interspinosus to the contralateral part. So my scope can bend forward, so
Yeah.
I can take out the superior, but I still cannot.
You cannot
And
because of the anatomy, and it is impossible to take out that part when you are working from posterior midline. That's why people have started going over the top, etc., etc. But there again, they cannot take it out. They only take out thing which lies below the facet joint, not above the SAP. Now, Dr. Vinod, do you have a comment? I see that you're trying to say something. Please go ahead. Dr. Vinod Jagtap. Hello.
sir, I'm going to
Yeah.
add something, sir.
Yeah, please. Dr.
Hello.
Adam, please go ahead. Oh, just
Uh,
Dr. Vinod, give a moment to Dr. Adam and then you can talk. Yeah.
there is a friend of mine. His name is Hanga Winam. You can search in
Okay.
PubMed, Hanga Winam. He is a student of Dr. Kang Tek Lim. He write about the para PSLD. So he put his scope PSLD likely 7 centimeter from paraspinal, and it cut the isthmus and show the foramen. So he can clear this kind of the flavum similar to the transforaminal, but the angle is not like yours. I mean, your technique is truly foraminal, but this is para PSLD is in between. It can clear the ligamentum flavum. You can read the PubMed Hanga Winam. 8 minutes.
Maybe we can
Para
interact with him
PSLD.
the next time. You can invite him to join our meeting and we can talk about it.
Yeah,
So,
yes,
Dr.
sir.
Vinod, you were saying something?
Yes, sir.
Yeah, go ahead.
My understanding when I see the MRI, my understanding now much improved to correlate the pain symptoms what the patient came with, and it is now become more easier to explain the patient what why he is suffering, and this give me some sort of confidence that I can relieve his symptoms, and this is the advantage which I feel the transforaminal surgery over the open surgery.
Yeah.
Can that we can give the at least some assurance that we know better and why he is suffering.
True. So we'll go ahead with that part, which will clarify now how to read the MRI, how to go for those zones and all those secrets which we have been withholding. Now, this is the upper zone. Okay, what you need to understand here is we are looking at a cross section, axial cut in the upper part or just above the disc, just below the pedicle, and here you can see the nerve going out, and on the left image you see the upper zone. On the right we slowly see we are coming towards the middle zone. Now in this upper zone anterior wall is above the end plate. This is the body of the vertebra above, and this is what is the upper zone, this whole thing. Okay, this lies below the lower part of the lamina, and here you will see this blue thing which I have drawn right up to here. So this is the upper canal zone. There are three important things to be noted here. See this line which I have drawn? This is the inferior end plate line. This line always is above the superior articular process, which is somewhat like this. Or you can say this line is above this facet, this inferior facet, the articular portion. The other thing which is important is inside the canal. If you see this here, this is where you will find the ligamentum flavum is attached below this. Okay, so in the upper zone, there is no ligamentum flavum which is closer to the nerves. It is only the ligamentum flavum which comes here in the upper part. I hope this is very clear to each one of you, and we will go ahead. But please remember that this inferior end plate line is very, very important. Why? Because that is the border between the upper zone and the middle zone. Now here is a picture which was sent to me by Dr. Sunil. This is a CT reconstructed. This is an osteophyte, which is seen commonly at this inferior end plate line, which is normally going up like this. So you can imagine that this will involve the nerve, which is exiting here, and this osteophyte can cause the stenotic symptoms. On the right side, you will see I have drawn a blue crescent on the tip of the SAP. Now, this is the tissue which is very important for us. The tissue above this up to the upper pedicle, that is the tissue here. I'm sorry, this is... I'm not good at using this somehow. Suddenly it has become difficult to use. Okay, you see the blue crescent. From this crescent to the upper pedicle is the pars, and under the pars would be the ligamentum flavum, which would be very important, and we need to concentrate. Now here is the SAP. As you can see, this is the right-sided SAP, the left-sided SAP, left-sided foramen, and you can see the right-sided curate, which is going to work on this SAP, cut the SAP, and then we remove the tissue which lies from the SAP to the upper pedicle. Now here you can see that in the upper zone, what causes the symptoms is only the tissue which is lying here over the axilla. All the tissue here in the central part of the canal is absolutely immaterial, doesn't mean anything, absolutely nothing related to stenosis. Here is the blue crescent which I have drawn, which will tell you that I enter in the foramen and then I go above the SAP towards the inner face of the facet to tackle the central canal stenosis or the real posterolateral canal stenosis. The same crescent shown in a cross section, in axial section, in the start of the middle zone or the lower part of the upper zone. You can see how the roots are lying inside the thecal sac. Now this is a picture from one of my live surgeries where you see the right-sided foramen, the SAP on the left, the roof here. You can see the blue arrow, double-headed arrow, showing you the space created after removal of the soft tissue here, which was the ligamentum flavum, and you can see the exiting nerve here on the right side coming out. Now, this is another important concept which I'm trying to tell you is that you have the SAP, and then there is a cone-like tissue, which is the tissue on the top of the SAP, the ligamentum flavum, the capsule, the superior transforaminal ligament, etc. And the apex of this cone is hitting the axilla on the right side here. So upper zone is seen here. It shows the SAP. It shows the space created between the SAP and pedicle above, and the cone is a soft tissue which is between the tip of the SAP and the pedicle above. So this was about the upper zone. Now we come to the middle zone. Middle zone is the discal area where you have the facet joint. You are seeing the disc in cross section. And now this is a very important point. The point is the ligamentum flavum, which you see here, is not attached to the bone. This is the interlaminar ligamentum flavum. It is in the window, and this is the ligamentum flavum which we are looking at is attached to the under surface of the upper lamina. Now here I would like to point out that the orange is the middle zone, and what I am pointing out with the double-headed arrow is the pincer of the facets. It's like a V-shaped thing which is grabbing the dural sac and compressing it from both the sides. This again, as I said, is from the model which Dr. Ankit has made, and we are looking from the ventral aspect of the spinal segment. Now here is one more cadaver dissection. The vertical arrows pointing down are the age of the facet, and in the upper part I have drawn a V. This V is supposed to show you the ligamentum flavum. You can imagine that the apex of the V is not important. The base of the V or the arms of the V are important, and they are the ones which are causing the stenosis in the central canal or the posterolateral canal stenosis, or the middle zone as we call it. Now this is from one of my surgeries. You can see on the left a transforaminal view. You can see the facet denuded of this soft tissue, and then we are drilling the facet, and the lower image is showing you also the lower zone towards the left. So we completely decompress the nerve lying below the facet, inside the facet, etc. Now this is an axial section which will show you, this is the lamina, this is the facet joint which you see. Please appreciate the 45-degree facet which is seen very clearly, and you can see the soft tissue which is lying on the inside of the facet, which causes the stenotic changes rather than the posterior midline structure which causes the stenosis. The same thing seen here, where you see the facet inclination which is about 45. You can see the nerve which is towards the pedicle going inside the root canal, etc., leaving the middle zone. So this completes the middle zone description. Now we come to the lower zone, where you see the cuts in the lower part of the discal end plate, then the lateral races, as you can see very clearly, and you can see the ligamentum flavum lying there. Now here, please remember the image on the left above is the one where I have drawn a black plane. Here I want to emphasize one simple point, and the point is like this, that this area which I am drawing a circle is called as a soft tissue lateral races. Now what happens is the disc may bulge. The annulus here, the posterior annulus, is not from one end plate to another end plate. It is more like this. I mean, the lower part is more like this. There is a pouch like this. So it is attached little loose here, and this is what may bulge and cause a soft tissue lateral races. The image on the right is showing a blue arrow showing the nerve entering this, and you will find that the ligamentum flavum may or may not be present in this area. It is also shown here in the lower left corner, and it is also shown in the middle lower image, that is the edge of the lamina on which I am drawing now, where the ligamentum flavum is. And you will appreciate that the ligamentum flavum will be here on the edge of the lamina. The nerve which is entering the root canal will be here and here. So please remember that we need to understand these variables about which I'm going to talk in next 1 minute or so. Let me erase this so that it is much more cleaner again. And so here again, I'm repeating, you can see the laminar edge which will have the ligamentum flavum. We are looking at the vertebral body from above. There is the edge of the facet. I mean, the inferior articular process will come here, and the facet edge is this. This is the lateral races, and this is where the traversing nerve is entering the root canal, and this is where we may have a soft tissue or a bony lateral races. Please remember that the width, I mean not width, the height of the pedicle is the distance between this green thing and the lamina or the ligamentum flavum. So a lateral races is a real anatomical entity here, which is a big area with a posterior wall and an anterior wall and the lateral wall, which is the pedicle. This again is the same vertebra now looked at from below. You can see the other side pedicle, which will have the root coming from here. Let me draw the thing so that it is much more clear. See, the root will enter here, then it will go along like this, and this root will go along and then go like this. So please remember that the root, when it is beyond this, that is where the ridge is here, where the lower lamina, which is sloping away, his root has already gone out. So we are more concerned with this part of the root, which is entering the root canal. Now this is the edge of the lamina and the facet edge, and this is the body. And there is so much distance between the anterior and posterior wall. So we need to understand that this lateral recess is not a very tiny area, and just de-roofing the lateral recess does not mean much. Now this is a coronal section. Why coronal? Because easier for us to understand for those of us who do open surgery from posterior midline. You can see here that this is where the root is entering the lateral recess. This is the ligamentum flavum. This would be the pedicle up and pedicle down here. This root will go in the root canal and come out. So we are more concerned with this area in the lateral recess. And I hope this has clarified the anatomy for you, which will make you understand our concepts better. This again is the same thing. You can see on the lower right side, the lateral recess, the root is entering there, going below the pedicle. Now this is from a paper in the past, which is talking about the facet angles. And you can see around L4 and L5. L4 is around 33 degrees and L5 is around 45 degrees. So commonly it will be a little more at L5, little less at L4. This again is one more cut, which is at the lower zone or the lateral. You can see on the other side of the picture, the roots entering the foramen or the root canal, and this clarifies to us that we are much away from the posterior midline. Now this is the way we approach that area, landing in the foramen, in the mid pedicle line towards the lower end plate, and this is where we'll be dealing with it. This is one of my surgeries where you can see that on the first picture, that is on the left up, you see the lower zone, you can see the lower pedicle and the SAP climbing up. The second picture, you see the nerve entering the lower zone. And in the third picture, this is the middle zone plus the lower zone. I mean, let me point it out again on this, that this is the climbing up on the SAP from the lower pedicle. This is where the root is entering the lower zone, and this is the middle zone, the central canal. This is where the root will enter the lower zone. I hope this is clear. And there's some noise there. Please mute yourself. So now coming to the last few concepts, what are the variables in the lateral recess or lower zone? We have to remember and find out where is the root leaving the sac. I mean, the root leaves the sac and becomes exiting. I mean, becomes the early part of traversing, then the exiting. We have to see the relation of the root to the ventral and the dorsal wall in the upper and middle part of the lateral recess. We need to appreciate the root along the pedicle groove, which I showed you. We need to see the laminar angle at the midline posterior, whether the lamina is acute or obtuse. We see the facet inclination. We see the pedicle length. We see the anterior upper part of lateral recess, where the soft tissue lateral recess is there. We see the posterior wall with facet changes, which may have a cyst, a synovial cyst, and we will see the ligamentum flavum going across the facet joint may not be covering the lower pole. And the facet cysts are commonly seen in the middle and lower zone only. Why? Because there is no facet joint in the upper zone. So that is completion of my three-zone thing. We will again take a break, have some comments before we probably will be concluding very soon. I see that it's almost 8:25, so no issues. So if there are any comments, please go ahead. Please unmute yourself, start your video, and give your comment. Yeah, Dr. Vinod, you would like to say something? Okay, anyone else who would like to have a comment on what I just mentioned? Dr. Palani, are you there?
Sir, I think that I'm Dr. Hilol.
Yeah.
I think that we need to have an appreciation between the parasagittal sagittal cuts between CT and MRI. Anybody who is able to judge from the, I mean, it's very difficult to convince a patient to do CT and MRI together,
Yeah.
but at least from the learning perspective, if we can understand about, say, 10 millimeters from the midline, the parasagittal anatomy, going right through the foramen, then not only we can, I mean, the radiological algorithm to figure out which zone to target will become much easier, especially when you are in the learning phase. That's what my understanding is.
Yeah, I agree with you. I do have those cuts, but on the models, not the actual CT and MRI. As you rightly said, that routinely we don't pay attention to that. But I'm working on it with my MRI person. I would also like you to, I mean, contribute to that part. That is parasagittal sections, especially. Actually, you see, what we'll have to do is to build up the anatomy from inside the canal towards the foramen, coming out of the foramen. And that would give us the clear posterolateral understanding of the canal and the true subarticular zone, that is the ligamentum flavum. Actually, what I would like to understand more, I do, but I need to improve my understanding, is the ligamentum flavum going up towards the upper part of the foramen. The facet edges are being covered by the subarticular part, and the roots crossing that. I mean, the ligamentum flavum and the roots are at cross. So there is a very complex tissue in the foramen, which I call as a G knot. And that knot is formed by the tissue on the lower end plate of the upper vertebra, on the tip of the superior articular process, the foraminal ligaments, the hypertrophied soft tissue, etc. So that knot of tissue in some patients, which we see, is involving the root above, exudating, the thecal sac on the medial side, the tip of the SAP below, the end plate in the front, etc., etc. So it's a very complex sort of tissue which could be hardened, collagenized, calcified, ossified also in some patients. So that is something which we need to work on. Now, for those of you who have not seen our demonstration of the fulcrum concept which I am introducing, I'll quickly just now show a few slides. Those of us who were there in Dearborn have seen that. So just a few slides to show you. This is what we have. This vertical shadow which you see, paraspinal or just outside the foramen, is an implant which is put on the transverse process. Okay, and I'm putting my dilator above or dorsal to that implant. And here on the right side, you will see that it is now in apposition to the facet joint. So this is our extraforaminal fulcrum, which in my language, my mother tongue Marathi, is called a teku, or teku means fulcrum. So this I use as an extraforaminal fulcrum. And what is the point here? I have separated in space my landing spot, my fulcrum, that is my working area, and my fulcrum area or anchoring area is separated. This is where I put my cannula over that, and this is where I'm working towards the upper zone and middle zone junction, mainly for the stenotic part of it. Please remember, I'm outside the disc. I'm on the under surface of the facet, and I'm extremely sure about it. Why? Because I can maneuver my instruments on this fulcrum, which is outside the foramen. Finally, this is a sum up slide of the 3-zone concept. The blue is the upper zone, the orange in the middle zone, the green is the lower zone. And in the lower zone, that circle is mainly the lateral recess. And this is the way we access our stenotic patients and treat them. Now that completes my presentation. Now I have theoretically 2 more things with me. If you want, I can quickly show you. One is a 3D model on which I routinely work. Let me just I'll just quit this and okay, now here, okay, I'll just try to share that for a moment so that some of you can appreciate it. Now, are you able to see the 3D model? Hello.
Yes, sir.
Yeah, so
Yes,
this
sir.
is a 3D model, and you can see what we can do with this. This is a degenerated lumbar spine. We are looking through the disc, and we are looking at the middle zone. We are looking at the tip of the SAP here. Now here, if we see on the, this is the subpars area, the upper zone from the end plate up to the pedicle above. This is the upper zone, this is the middle zone. And if we tilt it, you can look down in the lower zone. So like this, you can see the lower zone very clearly. You can see the lower zone of the opposite side with the facet here. So this was one thing which I thought I'll show you. There's one more thing which I will show for a second. Okay, so there is one more thing, is this anatomy which you see in 3D. Quickly, I'll take just half a minute. Are you able to see this? Yeah. So here what you are able to see is the complete 3D anatomy. You can magnify it, you can go in the foramen. The only problem with this model, 3D anatomy, is the nerve root is not shown closer to the pedicle. So it makes a little bit of a problem to understand the axilla properly. And you can cut off some part of this. You can in fact go inside the canal. You can see most of the things, maneuver them as you wish, look at the foramen, etc. So I thought that this could be a big aid to our understanding. So I have completed my presentation. I'm open for questions or comments, or, I mean, as I said, we need to co-create this concept. I completely appreciate the contribution which Dr. Hillol has given all these days, contribution by Dr. Ankit Madharia, and all of you, of course, whenever we have interacted on this. So any questions, comments, anything which you feel can improve our understanding or our interaction, please, please let us know. Please do tell me. And you can unmute yourself and you can make your comments. You can also please start your video so that we know who is speaking if we are not known to each other. I mean, that would make it a little more easy for us to understand each other. Dr. Ashish, would you like to comment?
Dr. Gore, I think what we discussed earlier, but thing is that I'm still a novice. I mean, I just attended one workshop, tried to understand the concept in that, having attended your webinars before that, and I'm beginning to learn how to put the needle and this and that.
No, my question to you is simple. Yes. It will help you in commenting.
Yes,
From your perspective of a posterior midline or posterolateral surgeon, as to put
Yeah.
it in simple words,
sure.
how do you take this, what we are talking? Do you think this is complete nonsense? Do you think this has some point? Do you think we need to work on what part of it, which will make
I
it more
will,
convincing?
I will answer you in a very simple manner. I came back from the Darwan workshop,
Yeah.
and I've been doing regular OPDs and seeing patients since then. And I think I shared with you. Now, when I see the patient and I see the MRI of the patient, I only think, how would I do it laterally? Posteriorly, I can do. All of us can do. There's no point. I mean, spent 30 years doing it posteriorly. Hilol has done it much more.
Yeah.
Now, when I see the MRI, my mind works forcefully into thinking how to do it from the lateral side. That is the impact of that. I don't have to make any further comment because that's the impact of the whole thing.
Yeah. I think Dr. Hillol was pointing out the same thing when he said that we need to improve our mental imagery
Yes.
and probably create a big magnet to attract our attention to that foraminal area. Whatever way, I mean, you look at it from behind, you look at it from side, whatever, but ultimately it will have to be that area which lies probably lateral to the facetal edge up to the lateral pedicle line, which is what we call as foramen conventionally. So the roof of the foramen, the roof of the upper part of the foramen, roof of the middle or the lower part of the foramen, and then of course we go to the lateral recess. So I completely agree. We have been working on the same thing, and fortunately we have made some progress as compared to what we used to do in the past. I think we have adequate inputs now, and we'll grow on that. We'll build on that so that now, yeah.
Should I say something?
Yeah, please go ahead.
So this time in the Devon workshop, the full new concept have gone through this upper zone, middle zone, and lower zone. And what regularly I'm realizing, being into anatomy also, the middle zone is so important because basically in the middle zone, if you see the MRI, our the most important part of the nerve is our dorsal root ganglion. So that is so much clear.
It is in the upper zone.
So yeah, so but there where pictures are so clear in that area also. So we are giving more space to the dorsal root ganglion. We are giving more air to the dorsal root ganglion, more nutrition to the dorsal root ganglion. Basically, that is the ultimate target because dorsal root ganglions are the head of the all nerves, those who are carrying the pain. So if we can
We call it as a mini brain of the segment. It is controlling that segment, L4-5, for example.
Them. So automatically patients relieving comes. I feel that also we are giving maximally in this route.
Yeah. What you have said is extremely important. Actually, I forgot to emphasize that all this business of stenosis is actually happening in the middle zone only, primarily, and then at the borders with the upper zone and border of the lower zone. The primary change is in the soft tissues of the middle zone, and these changes are in three causes. So let's now summarize. There are three walls, the anterior, lateral, and the posterior. There are three causes: the disc and its margins, the facet and its margins, and the ligamentum flavum. Nothing else. There is nothing else which is changing. And the important point is the bones are not changing. The vertebral bodies are not changing. It is only the coating of the facet joint and the coating of the walls which is changing. So cutting the bone apparently looks to be unnecessary or excessive when we talk about lumbar canal stenosis and the surgery which we do. So my simple message is please rethink on lumbar canal stenosis. Please try to appreciate that a patient can be operated under local anesthesia when you go through the foramen, and you can access almost all the causes. I will summarize them. In the upper zone, it is the lateral ligamentum flavum under the pars or the osteophyte at the lower, at the upper end plate with respect to the disc. In the central canal stenosis or the middle zone, it is the medial face of the facet which is actually causing the issue. So if you undercut the facet, cut the ventral face of the facet, go for the ligamentum flavum inside, also from above the SAP, you can take care of the central canal stenosis. If you go for the lower zone, go towards the lower part of the foramen, go to the entry part of the lateral races, go ventral to the root first, finish up that job, then you can come dorsal to the root and do that job as per the requirement of that particular person, rather than doing medial facetectomy as a rule for everyone. So this in short can summarize our philosophy of lumbar canal stenosis. Now I see Madhujit, you would like to say something?
Yes, sir.
Yeah.
I just wanted to know, how do you deal with the, patients having neurological claudication, like they have multiple level issues.
Correct.
And how do you deal? Do you do
I'll answer your question very simply. When a patient comes with multi-level stenosis, there is a technology in MRI which is called as diffusion tensor imaging, DTI. So you can ask the MRI fellow to give you a DTI which identifies the root which is primarily causing the main complaints. I mean, MR technology solves this point very easily. A practical answer is, if you don't have DTI, you can concentrate on L3-4 and L4-5 because these are the commonest ones which are involved in stenosis. Now, mark my word, L5-S1 is commonly not very stenotic. Okay. And then what you could do is you could be smart and do one level at a time under local anesthesia. Tell the patient that I would wait for the second level, which I'll do in the second sitting. I always feel that we have to learn from our dentist surgeon friends, where they do a tiny 1 millimeter job in 10 sittings and they make it look glamorous. You know, I do in 10 sittings, whereas we poor spine surgeons have to finish everything in one sitting. Why? There is no compulsion on us. If we counsel our patients properly and tell them that the problem is at 3, 4, 5 places, and I will tackle them by one. I mean, I will tackle them by going for the 4, 5 first, then going for 3, 4, whatever. I hope that answered your question.
Yes, sir. And what are the chances of instability if we address multiple level, bilaterally? Like
there's no question of instability created by your surgery. The instability which is present before surgery, if it is milder, may increase. If you are removing the annulus, you are doing too much of annulectomy, it may increase. Now that can be understood easily by looking at the axial sections in the MRI and looking for a wet facet, as it is called, or an open facet. And if you find that there is a micro instability, actually, you will find that those who have micro instability will have more soft tissue hypertrophy. That is what we see commonly, correct? There's a lot of hypertrophy on the undersurface of the facet if the facet is unstable a little bit. You need to tell the patient that this instability may increase. Anyway, please remember, you have to counsel the patient, telling them that whatever we are doing is not a permanent, lifelong solution forever. This is a solution for a length of time. This may manifest again in a different fashion. So surgery-created instability by transforaminal endoscopy is extremely minimal. Is it zero? No. Is it, as to be worried about? No. Do you need to fix that patient? I don't think so. Now, if you have a grade 1 listhesis or less than grade 1 listhesis, then of course we now have a spacer which we put inside the disc space under local and jack up the disc space or hold the disc space. So that may be used in patients who have a intact posterior tension band and need something to support that micro instability. So that is possible.
Okay, sir. Thank you, sir.
Yeah, welcome. Now, I see some people who I'm not very, I mean, I don't know them personally. Dr. Hari Prasad, if you have any comments, Dr. Vikram Singh Nangre, if you have any comment, please go ahead. Otherwise, we are going to wind up in another maybe few more minutes. Yeah, some comments on facet joint capsular, yeah, into canal middle lower zone. Yeah. Okay, Dr. Jagtap has asked me about some comments on facet joint capsular osteophytes or hypertrophy encroaching medially into the canal in middle and lower zone. You see, in the lower zone, we were unnecessarily told that you cannot reach that area. It's not true. I can definitely reach that area under the facet, dorsal to the nerve, but ventral to the facet in the lower zone. About the medial thing, I'll tell you something simple. As a beginner, what you can do is you do a arthrogram. That is, you put a needle percutaneous, a 18 gauge or a 20 gauge spinal needle in the facet joint, and you inject dye. When you inject the dye, you will be able to appreciate the joint space in the AP of the C-arm and the lateral, and you will be able to see where exactly is the age of the facet. Let us say that the age is about 2 millimeters inside the medial pedicle line. Now, the problem which we have in our mind is, I'm going to land in the disc when I go at that angle. How can I go up? That is where that fulcrum thing which I talked about is important. And then actually, as a practical day-to-day solution is, you stay closer to the facet when you go in the foramen. You graze the facet, and then you can easily undercut the facet. You can undercut the ventral surface of the facet till you see on the upper side, you see, or in the upper part of the foramen, you see the inferior articular process. You follow that, and you will then be able to go to the edge of the facet and the hypertrophy on the edge of the facet. So it is going through the foramen, but not under the facet completely. It is on the edge, upper edge of the facet, and then go inside. I hope you, that crescent which I had drawn, the blue crescent is what you follow. You go on the SAP, tip of the SAP, and go inside, and then follow that, and also do under the facet. So these two combined will give you a clue to the medial face of the facet or the edge of the facet, hypertrophy or osteophyte. Yeah, you want to say something more? Okay, if there are any more comments, please let me know. Dr. Dhanashekharan, Dr. Zaki, Dr. Nordin, Dr. Pravesh, Dr. Hari Prasad, Dr. Palani, Dr. Faizan. Yeah, Dr. Nordin, go ahead.
Yes, sir. Thank you. Very nice talk today there. I would like to ask you about this ligamentum flavum hypertrophy. Is it true hypertrophy, or is it because of anatomical changes in the facet joint that cause buckling of this ligamentum flavum? Can you clarify that, sir?
If you ask me, I would say there is no ligamentum flavum hypertrophy. There is laxity of the ligament. Normally it is stretched between the ventral attachment to the upper lamina and the edge of the lamina below. It is stretched. It is a very tightly stretched structure. When there is a collapse of the disc, it may have a little bit of bulging towards the inside, and that may be labeled as hypertrophy. You see, these terms of the past have less meaning today, because even if it is hypertrophy in the central part, that is the closer to the midline part, it doesn't cause any symptoms. It is an optical illusion created by the actual sections taken in the plane of the disc. The ligamentum flavum is not in the plane of the disc. It is obliquely going up. And if you read the ligamentum flavum anatomy well, you will find there's nothing like hypertrophy. Okay, there is hypertrophy in the lateral portion. You see, I would also agree on one point, that there is no better word in English to describe that ligamentum flavum which we deal with. So the word hypertrophy may be used, but with a correction that the lateral part of the ligamentum flavum in the upper zone and the posterolateral part in the middle zone and maybe remaining posterior part in the lower zone has to be paid attention to, not the posterior midline part. That is my take on that. But I'm open. If somebody says, no, 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 there is hypertrophy, okay, I understand. I mean, you're not against that point that there is hypertrophy, but it doesn't solve our problems. Calling it hypertrophy doesn't make us wiser. Calling it hypertrophy doesn't take us to the target, which is actually not posterior midline. So if you want to call it hypertrophy, you call it. But remember, it is posterolateral or lateral part, not the middle part. Okay, so if there are any more comments, please let me know. Otherwise, we'll wind up. It is 8:51, almost an hour and 50 minutes. We are interacting on this issue. I hope we made some difference to the understanding of this concept, and we have tried to share with you our understanding. We would be open to any of the comments which you have to offer, any suggestions which you have to offer to make this more meaningful to your work. Before I close, I thank Dr. Hillol for contributing a lot of images to our understanding. Dr. Ankit, who has made that 3D printed image, and Dr. Ashish and Dr. Tarun, Dr. Vinod, who have actively commented on our work. Dr. Mukesh also. Very soon we'll be interacting, Dr. Mukesh. So
can I make a comment?
Yeah, sure. Why not?
Actually, when it comes to a lumbar disc herniation, there is no confusion. I mean, we have been seeing it for such a long time. But actually, the word is demystifying. When it comes to lumbar canal stenosis, every case we have to demystify as to what is the compressive element, what is the chemical irritation because of a disc herniation or an annular tear and all that. And third is which is exactly the component which is pressing and causing the symptoms, whether it is vascular ischemia, whether it is compression. So I agree with your concept that like a dental surgeon, we should at a given moment of time in a patient's natural history, decide that this is the most symptomatic compressive element which I can deal with in this particular zone. So if we go stepwise, I mean, in the beginning, we will have to face this, that patients will say that, this guy operates at least 2 or 3 times. There are many things which can circulate. But when it comes to understanding the lumbar canal stenosis, I sent you that nomenclature paper of lumbar canal stenosis, which has come from WFNS. And you can see the lack of clarity. So I think that demystifying each and every lumbar canal stenosis case should be the way. And in that analysis of the parasagittal anatomy is actually the key point. That is what is my understanding at the moment.
Yeah, I completely agree with you. Yeah, just one moment, Ashish, before I completely agree with you, Dr. Hillol. What I personally feel is, let us put it this way, that in case of disc herniation, our job is very easy because the pain generator guides us to that spot. And then you go on along that logical way. In case of stenosis, unfortunately, the images decide a lot about our decision making. And unfortunately, again, our imaging specialists have not contributed anything about the variables which we have to deal with. For example, in the upper zone, I would say that the location of the dorsaloid ganglion, the presence of osteophyte, presence of lateral ligamentum flavum must be commented by the imaging specialist if there is a stenotic element in the upper zone. In the middle zone, they must say that the facet is inclined in this degree, that degree. They must say that the hypertrophy around the tip of the SAP and the inside of the facet is this, these many millimeters, etc. And they must start doing the coronal oblique imaging, which is in plane of the upward going oblique ligamentum flavum. In the lateral races, I mentioned a couple of variables like the root exiting the thecal sac, the angle at which it is going, the laminar angle, etc., etc. So it would be further refining our imaging report, which will actually start this change in thinking in lumbar canal stenosis. It is not only the surgeon who will be able to make the whole change. The imaging people will have to contribute in a big way in giving us crystal clear idea about all the variables, where the real picture will then emerge that our 3, 4, 5 spots need attention. Maybe one of them we tackle today, one of them we tackle tomorrow, whatever. Yeah, Dr. Ashish, you wanted to say something.
No, it's nothing important. There's just a light comment I wanted to make.
Okay.
If I may compare the two methods of treatment, one is the conventional and the one focused one which you are describing.
Yeah.
It's more like punishing the classroom student who was making the mischief.
Mm-hmm.
And the conventional was you slap the 4 guys sitting in that area and you just get out with it. Yeah, they must have been the ones making the problem. That's on a lighter moment.
True.
You slap all of them and one of them will be the culprit.
Yeah, correct. Yeah, that's very true. So I think we could probably come out with more meaningful points out of our discussion today. And I, for one, at least the message which I am taking home with me is we need to concentrate more on the variables. And as Dr. Hillol said, we need to concentrate on the parasagittal images. I would try and rope in a few imaging specialists next time with their bunch of images. I would probably have 4 or 5 MRI specialists. I'll invite them specifically for the session and ask them to give their comments and try to find out the secret or the real undercurrents, whether they report so as to please the surgeon. I mean, I'm making a joke here. It's in a lighter vein. That are they trying to please the surgeon by reporting the way they report, hiding the reality, or they are not also aware of the real focus which we need. So on that note, I think I'll conclude. I thank you all for joining us, and on a Sunday morning, it's more appreciated because otherwise it's a lazy morning and we tend to probably dream of spending it doing things which are away from the patients. So sorry for adding those painful spots in the morning, but I hope it improves our work over a period of time and makes us better surgeons for lumbar canal stenosis. So thank you very much. And I have recorded this session, so maybe I'll share a link with all of you. Those who want to see it again can always have a look at it again. So thank you very much and welcome everyone. Bye-bye.
Thanks.